The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone. This is Deanna Mitchell with Leading Age Michigan, and we've gathered everyone together this afternoon to discuss some of the provisions in the visitation order that we all know came out yesterday morning. And the reason why we've called this at this kind of late hour in the day is because we wanted to make sure that our members had enough time to consider all of the issues and discuss the issues before implementation, which is actually Monday. And there's an awful lot of areas that we need to discuss and talk about. And the department has also asked us to help inform them so that they can put out a Q&A document that would actually be helpful to our members as they try to implement these things. So one of the larger goals for tonight is to start to collect some of those questions and issues in terms of a list of things so that we can get it off to the department as soon as possible. So you can move the slide forward, Blake, please. So the residential care order came out yesterday morning. And of course, we all know at this point that it does not cover independent living. But it does cover nursing homes, unlicensed assisted living, adult foster care, and homes for the aged. But that doesn't mean that independent living doesn't have to think about this, because now they have to sort of undo all of the things that they were doing before and figure out how to kind of move on to a whole different scenario. So as I said before, it's effective on October 26th. So when we had our meeting with the department yesterday, we got some additional insight as to some of their intention, and a lot of that isn't 100% obvious in the document. And again, as I said, we were collecting questions and issues. So the plan for today is to review the guidance briefly, and then collect your initial questions, issues, and thoughts. The plan for tomorrow is we're going to go ahead and hold our 11 a.m. webinar, and then continue to collect questions and issues as facilities have had time to think about how they're going to operationalize the guidance. So the order itself, the first section, resident and employee protections, you'll note that this framework for this order is the same as some of the older executive orders. They were more clear in this order about limiting communal dining. They've taken out the piece that talks about MDHHS guidance, because they've decided there was some old guidance and they wanted to get rid of that idea, because the whole intention of that piece was to simply apply those QSO 2039 nursing home requirements to all of the settings. And that is still the expectation. So even though you're not a nursing home, you're still expected to look at QSO 2039, and we can send it to you if you need help finding it. Non-nursing homes aren't necessarily used to that. They're very general requirements about social distancing and things like that. There's nothing in there that would surprise you. It's very broad, but that is the expectation. Informing employees and residents of new cases within 12 hours. That is not new. Within 24 hours. This is actually not new either, but it is fairly recent, I would say, in the last month. Within 24 hours, you have to inform legal guardians or healthcare proxies, post a notice if you have any current COVID positive persons and who may be recuperating for at least 14 days after the last positive. You have to post a notice to that effect near your main entrance. You must implement a protocol to inform prospective residents and staff, and you have to keep that activated again for 14 days after the last positive. You must, of course, contact the local health department, and you must support and comply with contact tracing efforts. None of those things are brand new, but they are relatively new. Timely notification of CDC updates to employees, tracking of PPE, and reporting all presumed positive cases to MDHHS when required. They're talking about EM resource there. all of that is pretty much the same as it was. So, visitation itself. One of the things that they say up front is visitation is prohibited with the following exceptions. So they want to make sure that you understand that if there is no provision in this guidance that says you can do it, that means you cannot do it. So just to make that clear, there's a reason for that statement up front. Facilities, with some exceptions that we talk about later, may only permit visitation when meeting all the following criteria. No facility acquired cases or staff cases within 14 days. If the facility resides in a county where the current risk level on the My Safe Start webpage is low, A, B, C, or D, you can have indoor and outdoor visitation. For counties with current risk level E, only outdoor visitation is allowed, although I think there's some exceptions to that later on. And the local health department has not prohibited visitation at the facility. And I think that last piece is really important because as we look at the numbers, and I do almost every other day or so, they are rising rapidly. So I would expect that you might hear from your local health departments in terms of visitation going forward. So this is the infamous link that came with the press release. And to be honest with you, I've struggled with this for the last couple of days since this came out. This is the list and the basic risk level for each of the 83 or so counties in Michigan. And you'll notice that Kalamazoo is an E, and I'm using Kalamazoo as a example here only because I've been talking about Kalamazoo with 3 or 4 people throughout the day. So I'm very familiar with Kalamazoo. And Kalamazoo has a high transmission rate right now. So if you move forward to the next screen, Blake. Now, one of the dilemmas that I've always had with the My Safe Start page is that there's no place on it where you can really find the county overall risk level. That was my understanding before, and that continues to be my understanding now. If you click on Kalamazoo, as you see I've done in the upper left-hand corner, you will get the map, and I've cut off the bottom, but then you'll also get a map of Kalamazoo within its larger region. But all of those counties in that region, even though you clicked on Kalamazoo, will be the same color. And the reason for that is that there is no county level data in that map ever. It is all regional data. So if you click on Kalamazoo, you're going to get a color for that entire region and not just that county. If you click on epidemic spread, you're going to get 2 colors and 2 rates. One is for the test, the positivity rate, and the other is the new cases. And you'll notice, look at the wide variation between those colors. So you really can't tell the color code from the My Safe Start page. And until they update the actual map or do something else to this page, you're going to have to rely on that list. Now, how you get to that list after yesterday, I really don't know because they sent out a link to it. It's a PDF. It should be changing all the time. So we're going to have to look at how that plays out and where they're going to put that on a daily basis because I'm not sure how to get to it myself. So facilities allowing visitation shall, and they put this statement in there directly, without exception, will permit visits by appointment only. You may impose time limits. You have to require logging in and out. Visitors must provide contact information, attest to notifying symptoms. None of the things on this page are new. You still can limit the number of visitors. You have to 2 or fewer at any given time. Visitor to resident ratio can't be more than 2. For facilities who are currently required to test, you have to test visitors as described later. And what that means is, right now, that only nursing homes are going to be required to test visitors. HFAs, AFCs, assisted living are not going to be required to do that. You must exclude anyone able or unwilling to wear a face mask or wear PPE as required. Have to limit visitor entry to designated entrances. Screen all visitors each time, excluding anyone with symptoms. Post signage about the need for assessments and possible testing. So, except for the testing piece in this list, there isn't anything new here. So, this part is a little new and changed. Facilities must require that visitors follow physical distancing and refrain from contact, except visitors who, during ADL visits, for provision of medical services and for necessary non-medical services, those persons who are providing services that require physical contact are not expected to abide by physical distancing while providing services. They have to wear appropriate PPE. But one of the issues is that for all three of these areas, ADLs, medical services, non-medical services, it says the time spent can't be more than 15 minutes within 6 feet of the resident. So that might be a problem if you're trying to feed someone. And that has come up as an issue that people have been a little bit concerned about today. So that's something that we're going to have to talk to the department about. Visitors for end-of-life visits may have physical contact with the resident. As long as the resident is not COVID positive, visitors are wearing PPE, and the time spent, again, is no longer than 15 minutes. So additionally, I think that there's nothing new on this page, but making hand sanitizer and hand washing available, education to that effect. Availability of staff to assist with transition. I would prefer to say transfers or whatever, not transfers, but transporting. Monitoring, cleaning, educating if there's additional PPE needed, disallowing visitation for those high-risk procedures, restricting visitor movement, supporting visitation in designated areas for residents who share rooms. This question comes up a lot. So you are supposed to limit where visitors can be in your building, and they cannot be in a room with residents who are sharing rooms at the time. So you're going to have to find another place for those. But again, that's not new. Make available an employee trained in infection control at all times. That's an older one. They are a little bit more clear about the fact that they're not intended to supervise all the visits. You can have other people monitoring. Limiting the number of overall space visitors based on space, no sharing of food, communicating updated policies to residents and families. And the last one is not new either, but I think it's a bit of a problem because this has come up a couple times. Prohibiting visits to residents who are in isolation or otherwise under supervision. So if you have an end-of-life person who may have just come into the building as an admission, does that mean you cannot let a family member visit that end of life because they're in isolation? So that's one of the questions that we want to talk more to the department about as well. So outdoor visitation. Nothing new here. You must allow 6 feet between all persons. Tables, markings are recommended along with signage. You have to make sure that the visitation, that during the visitation there's adequate protection from the weather. We're going to talk about shelters a little bit later because there hasn't really been clear definitions about what the expectations are for an outdoor shelter. Visitation requirements, restrictions. This is a list of scenarios or categories where the visitation restrictions do not apply. So sometimes it's a little bit hard for people to understand that it means that window visits when it says visitation restrictions do not apply to window visits, this means that window visits are allowed, and they must be made available at all. So none of the indoor or outdoor rules apply, obviously, to window visits. They're all outdoor. But one of the pieces is they must be made available to all. So if you have persons on a second or third story, you need to figure out a way to allow them to have window visits as well. A visit of a parent or a guardian of anyone less than 21 is always allowed. I don't think we have a lot of that. I think mostly we have senior care in nursing homes. I think there's a rule about the age. For visits that support ADLs, there are no restrictions for visitation if you are providing ADLs for someone who needs help or they are failing. But they have a new rule here that says that facilities who deny this visitation must provide written notice to the visitor with a rationale about why you're denying that visitation. And it must be submitted to the department and to the long-term care ombudsman. The only reason that you wouldn't have to do that is if indeed the reason was that the resident the visitor was COVID positive. The same applies to visits that support end-of-life care. If you're denying any visitation, you're going to have to provide a written notice with rationale again. And the only reason why you can do that is if the visitor is COVID positive. Medical service providers, they are allowed indoors and outdoors. Outdoor visits are always recommended. They don't seem very practicable right now. There's the similar provisions for ventilation and restriction of those providers' movement through the facility as before. Same with non-medical service providers. Their work or services must be necessary to prevent negative impact on the resident, but the same conditions apply. Resident physicians and clinical students and volunteers are still allowed in your building. The volunteers, however, it seems have to be focused on scheduling, screening, escorting, and/or monitoring visitation. There doesn't seem to be any other voluntary activities that are allowed here right now. So testing, now this is the tricky part now. Testing is for nursing homes only, and it's required. Testing of visitors is required in risk level areas of C or D, except they're not required prior to window visits, obviously. No tests for that, and no tests for end-of-life visits. And this gets a little confusing to me when we look at the table that they've provided later. But the actual narrative says no testing is required for window or end-of-life visits. The testing requirement, for medical professionals, non-medical service providers, resident physicians, clinical students, and volunteers. Remember those 4 categories of people who are allowed into your facility. The testing for them must align with staff testing. So when they were talking about this, I assumed, and when I read it first very quickly yesterday, and a lot of other members believe that the testing aligning with staff testing was meant for visitors. It's not. It's only meant for these 4 categories of people. Testing is required for indoor visitation for C, D, and E counties using the MySafe Start map. Now that E is in there, and I believe that those are exception visits only that they're talking about for risk area of E. This is another important piece coming up. Facilities should conduct point-of-care testing of visitors whenever possible. So it felt like yesterday when we talked to the department that their whole program for testing visitors is built on point-of-care testing. So if that's not available, facilities should require visitors to test on their own within 72 hours of the visit and bring proof of negative testing. Now, what's important here, and what we've gotten probably more questions about than anything else in the last 24 hours, excuse me, is who's going to pay for that. And the department is working on additional guidance to that effect. Their plan right now is to provide point-of-care test kits to all nursing home facilities to support this. And if you do not have a machine or cannot get a machine for some reason, there is some discussion that they might provide that as well. But you do have to have a CLIA waiver on your own. So the department put together this handout, which I thought was very helpful, although I'm still a little confused about some of the pieces. But it is meant to be an easy guide to figure out what you can do and what you can't do. The visitation precautions are there. The county risk levels, low, A and B, C or D and E. Outdoor visits, yes, if there's no recent cases in the facility, you can do outdoor visits in all of those risk areas. You can do indoor visits in low, A and B if there's no recent cases in the facilities. That's that 14-day period you've got to worry about. And in areas of C and D, you can have indoor visits if you're testing your visitors and if there's no recent cases in the facility. Indoor visits not allowed for E. And that's, I think, a little confusing when we get to later information. Compassionate care, and I guess that's it there. Compassionate care is allowed. So to me, that's an indoor visit, but compassionate care for E and C and D are allowed if you do the visitor testing, except for end of life. But that is end of life. So these are the pieces that confuse me all the time, mostly about E, mostly about end of life and testing. So I find that confusing, and I guess we'll have to continue to work on that piece with the department. Compassionate care is obviously allowed in low A and B areas. So this is the more detailed grid. It has the special category or reason for the visit. Visits allowed regardless of county risk. Is there social distancing required? Is testing required? So you'll see that visits are allowed regardless of county risk or facility outbreak for window visits, parents, guardians, ADLs, end of life, serious or critical condition. I always kind of lump that in with end of life. Any medical service provider, non-medical service providers, though, are not allowed to come in if indeed there is a facility outbreak. So your hairdressers, etc., according to this, are not allowed to come in. I don't know that it said that before. Resident physicians or other clinical students, if you have an outbreak, it says no. I don't think it really said that before either. Volunteers who have been trained in infection control measures supporting visitation, obviously no, you're not going to have any visitation. Excuse me. Social distancing. Pretty much social distancing is required when it's not needed, obviously. ADL support, you need to get close to the resident. End of life visits are okay for contacting if it's limited to 15 minutes with PPE. And visits that support ADLs are supposed to have PPE as well. Excuse me. Pretty much the only other times that social distancing isn't required are when they're being people are being served, obviously, by medical service providers, hairdressers, and that's pretty much it for social distancing. Testing, there's no testing required for outdoor visits or window visits. If you're in C, D, and E, parents coming in, guardians coming in, but that's all for someone who's under 21. Visits that support ADLs, you have to test if you're in C, D, or E. End-of-life visits, again, I guess no testing. Visits that for serious critical condition, yes, but not end-of-life visits. And if you're in C, D, and E, and you're talking about indoor visitation. All the rest of the following, medical service, non-medical service, resident physicians and volunteers, they all have to be tested, but remember, they need to be tested along in alignment with your staff testing program. So I guess that this is pretty detailed. It should help because otherwise all these categories get somewhat confusing. So these are the questions and issues that we kind of have to date. A lot of questions about reimbursement for point of care and how members are going to manage testing. I added the question of how to access the county list on a daily basis. Someone asked if they were in risk level E, could they create a visiting room with its own entrance? So that visiting room, I believe, is inside the building. It has its own entrance with fully sealed glass or plexiglass between the visitor and the resident. Could we consider this a window visit? And that's a question that we're going to have to ask the state because actually you're stepping inside the building. What are the requirements or expectations for outdoor shelters? I've been struggling with this along with some members for a couple weeks. Really, what is allowed? Because sometimes, you know, if you build something fairly tightly, you're actually going to limit your ventilation. It really isn't outdoors, although there is the benefit that there is no external person who's unnecessarily coming into your building. Are those kinds of shelters okay? I've asked the state that, and they have referred me to the fire people, the local fire people, to identify what's okay. So I'm not sure if they just don't simply have rules for it, and as long as it's an external and distinct shelter, if it doesn't matter to them, but we still kind of lack guidance about that. A lot of CCRCs have common areas, common pathways, or they have adjoining buildings. And what will happen if you have a positive person in one part of the building or you have common areas between them? How are you going to think about that in terms of figuring out whether or not, number one, you can have visitation, or you're going to have to consider how to deal with an outbreak? That's been an ongoing question. We've always kind of said that if you don't have any people moving from one part of the building to another at all, in terms of staff, workers, nothing, no integrated pathways, no common areas between the two really that you're using that way, and that you're completely separate, that you could consider them separate. But this could be important if you have, let's say, a positive person in your independent living, and you are attached to assisted living and a nursing home. How are you going to think about that in terms of your visitation and your testing requirements? Someone asked if facilities cannot do testing, or they're uncomfortable doing point of care testing, or they're concerned about the accuracy. What direction will the department give? And as I said before, they really are focusing on the point of care test as the answer to the testing issue here. Another question, are we expected to do a point of care test on a family member if they're unable to get tested on their own? Again, their focus is to do the point of care testing as the primary method to fulfill the obligation to test for visitation. So I don't know how the department's going to think about that. Doctor's orders, how are they going to work? If you need a doctor's order for all these tests, how will that work really? That is going to be extremely burdensome, and we want to hear from the department about that. The director says indoor visits are allowed if providing services to residents, but they can be less than 6 feet away only for 15 minutes, and that's not enough time sometimes for ADL visits. Contractors, What is the status of contractors now? Before, contractors were only allowed in the building for absolutely required services, such as plumbing leaks, heating failures, etc., something that was essential in terms of maintaining your facility. Otherwise, they were only allowed to come into your facility in separate non-residential areas. Is that still true? We don't know anymore. Are they considered part of this visitation guidance or not? What do we do if we think visitation would not be safe? There are some facilities that are in really high transmission areas and they're worried. Even though we know that visitation is important, we also know that there are times when visitation would put our residents at more risk. And someone asked about hugging stations. And I'm not sure exactly what is meant by hugging station, but I have a sense that they're not going to be allowed. So we're going to talk about that too. So I'm going to stop talking now. And I would ask, does this list include what you care about? And do you have any other questions or issues either for us or for the department so that we can get on them right away and try and help everybody get ready for Monday? Blake? Oh. Well, let's do the questions first, Blake.
Okay, did you want me to just start from the very beginning questions? I would assume.
Yeah, because they're all about visitation.
Okay. All right, so let me go to the beginning here. All right, if we are testing family members, visitors, 1, who pays for the test? 2, if they visit weekly, can we test them weekly even if it's not always within the 72-hour period on our regular testing day?
So the idea again is the focus is on the point of care test, and the state plans to support that by providing test kit materials, and I believe that they will pay you specimen collection time as well, just like they do now. If you're doing a point of care test and someone comes in every week, you can do it right before they come in. The problem is that they're going to have to wait 15 or 20 minutes to get the results, and you're going to have to figure out how that would work, but I think that that's what's in the department's mind.
Okay. What are the PPE requirements for visitors? Is a mask enough? Do they need to have N95 or a surgical mask? Okay. Do visitors indoors additionally need a gown or face shield and gloves? What are people's understanding of required PPE?
My understanding is that if they're not touching the resident, they have to have a cloth mask at the very minimum, but they have to stay 6 feet away. If they're going to get closer, they're going to touch anything, they're going to have to wear whatever PPE your staff are wearing. So if this is a person who for ADL requirements, and if you are if they're getting close in terms of potential splashes, gloves, gown, mask, I would think at a minimum. Whatever PPE your staff are using for that resident is what person who's assisting with ADLs and or perhaps maybe an end-of-life contact visit would do. But most people are going to be 6 feet away at all times, therefore they only need a mask. But they also, remember, the visits must be supervised, are not allowed to come into that distance and not allowed to touch things. And things, of course, have to be disinfected at the end.
Okay. Where did you find the letter on the spread Michigan Safe Start? I checked Oakland today and it said C and you said D. I know you said you don't know how to find it. When I clicked on my county, it says C.
Please shoot me an email and we'll talk about it individually and we'll look at it together.
Okay. Is nothing changed in the isolation of new move-ins for 14 days?
That's correct. You still have to have transmission-based precautions, full PPE for 14 days, preferably in an observation unit.
Okay. So when reading the rules for EOL, when even in PPE, they cannot have close contact for greater than 15 minutes, that would mean they can sit at the bedside for 15 minutes and then they leave for the day, or then they just move back to 6 feet apart and cannot be close again for the rest of the visit?
I think that's a good question that we can ask. However, my thought was that they're only allowed close contact for 15 minutes. I think that they can stay as long as you allot them in terms of your visitation plan.
Okay. HFA is no longer reporting PPE in the portal. How are we to comply with the reporting requirement?
You don't have to.
Okay. How did you access the information on slide 5 that lists all the counties out with their risk level?
Okay, that is a link that is directly from the press release. So if you, or also I think it's in the guidance itself, but I could be wrong about that. But it's definitely in the press release that we sent out with the information. So if you click on that link, there's actually 2 links in there that will get you to the county list. And my understanding is that you have to abide by the county list that's in that PDF. But we will talk about the MySafe Start website with the department to try and figure out if there are discrepancies, where they are.
Okay. If you have a COVID-19 positive staff or resident, are both indoor and outdoor visits restricted for 14 days?
Yes.
Okay. The grid that was attached with the order is confusing related to the resident physicians or other clinical students. Under column where it says allowed regardless of county risk level, the answer is no. Can you clarify?
Can you go back to that graphic, please, Blake?
Yeah.
One more forward.
Was it?
It was right near the other graphic.
Okay. I'm sorry. I thought that it was fat.
There. Okay. So and now repeat the question.
The grid that was attached with the order is confusing related to related physicians or other clinical students. Under column where it says allowed regardless of county risk level, the answer is no. Can you clarify?
That's something that I had not anticipated. I really thought that county risk level or facility outbreak would not impact that. But according to this new guidance, resident physicians and clinical students are not allowed in your building if you have a facility outbreak or a high county risk level.
Okay. So if we are in level E, what visitors do we need to test? Any?
Well, if you're in level E, I think that you are only allowed end of life visits and ADL visits, if I'm not mistaken. Isn't that correct? You're not allowed indoor visits. You're allowed outdoor visits, and you're allowed end of life visits and ADL visits. Of course, you can allow your personnel, your external personnel to come in, but if you're in E, you're not allowed any indoor visits for regular visitors except for end of life and ADL care. That's my understanding.
Okay. Weekly staff testing is time consuming enough as it is. Now we have to test visitors as well. Can we train different staff on how to use the POC machine so one person isn't just a professional COVID tester?
This question actually came up a long time ago about whether or not a person can be trained to do the testing. And as far as I know, that there is no requirement that someone be a licensed nurse or something to do the testing. I would think that you would be able to train people to do that. However, we'll put it on our list.
Okay. EPOC testing was meant to be used with symptomatic people. Is there concern that if people are not symptomatic, that this won't be a reliable test?
No, I don't have that concern. The CDC doesn't have that concern, mostly because those tests are meant to be followed up on an ongoing basis. It is true that if you have an occasional visitor and you test them once using a POC test, that you don't have that repetitive testing that is meant to identify a positive that might have been a false negative before. But the POC tests are pretty effective in screening large numbers of people. That is the thought of almost everyone at this point. So I think that is probably the most practical way, actually, to test these visitors.
Okay. Testing for vendors, non-medical service provider only used to need testing if in facility 8 or more hours. Does the 8 hours still exist or all need testing?
Good question. We'll put that on our list. You're correct. I do know that that's separate MDHHS guidance in their testing FAQs. They do identify that. It is not clear in this guidance whether or not those rules still hold. So we'll add that to our list for the state.
Okay. Does hospice providers include all disciplines for the hospice team?
I believe so, as long as they're considered essential to the care.
Does it have to be a nurse who is using the testing machine, or well, I think we already answered that.
Right.
Are we supposed to be testing visitors inside the building or outside? What if they are positive and we let them in the building for testing?
That's a good question. I would always assume that you should be testing in some place that would be considered out of the way of any normal pathways and would not necessarily require walking into the building itself for testing. So we can ask that question about how that expectation is. It is going to get cold outside. That's going to be probably hard. You could test in cars, but that feels burdensome as well. But we'll get the department's response to that.
What if we do not have point of care testing available?
Well, my feeling is that that's the primary mechanism that they plan to use here. And we're not exactly sure how that's all going to play out. But I believe that they will provide you a machine if you have no other means of getting one, along with test kits. But that does mean that you have to get a CLIA waiver. If you choose not to do that, I think that this is going to be rather challenging. I think it's challenging anyway, but it's going to be even more challenging for you to have visitation.
What is the facility's responsibility if the potential visitor tests positive with the POC testing?
Well, obviously you don't let them in. I don't know if you have to report it, though. That's a good question right there, because if you've never let them in, they're not really I think that you don't have to report that personally, but I think that just notifying them and asking them to follow up with their own physician would probably be enough. But I think that's an excellent question. We'll add it to our list.
Our ILF and ALF share some common dining and activity spaces in one integrated building. How does the department suggest we handle the exclusion of IL with respect to the new indoor visitation orders?
That's exactly one of our questions that we've already put on our list. What if you have common areas, and what if you have pathways and adjoining buildings that are really intermingled to some degree? I think that might be a challenge. If you're allowed to have pretty much unrestricted visitation in IL, that could be a problem for a SNF and or assisted living. We will be discussing that and adding that to our list for the department to respond to.
Where can we find the MDHHS graphic that summarizes the visitation order?
You're talking about the one that's right in front of us right now, I'm assuming. It is a link at the bottom of the press release. However, we can also send it out to everyone.
Okay. Just forewarning, this next one is decently long, so
Okay.
we have protected our residents for 7 months against the pandemic. The number of cases are rising, schools are closing and going to virtual learning, and it would be safe to say we are upon another wave. It has realized the importance of visiting. We have had great outdoor visits and emotional moments with residents seeing their loved ones in person for the first time in many months. Following the precautions, of course, how can we start allowing indoor visits when the rise in cases is increasing? We have worked diligently to prevent and allowing indoor visits may change things as they will now be in an enclosed area. Telecommunication is strongly presented, and yet we are to allow visitation with anyone who passes screening testing.
That's a very good question. I think that really there's only a couple places in here where you have to allow visitors, and that is for end of life and ADL care. Not, withstanding all of the other non-medical service providers and medical service providers. I have had the same question. I mean, the timing of this would have been much better in the summer when the caseloads were lower. The caseloads are rapidly rising. Hospitalizations are rapidly rising. And so there could be some concern there. My suggestion is that you start out with your local health department, because your local health department has the ability to shut down visitation in your area at a moment's notice if they think it's unsafe. And if you think it's unsafe, I think you should be coordinating with them. Other than that, we can ask the department, since there's only a couple instances where you have to provide indoor visitation, although it might be a public media, I don't know if media is the right word, it might be a public problem with your families if you don't allow visitation if they know that other places are. That might be a difficult place to be in, but you do have to continue to protect your residents, and you need to figure out how best to make all this work for them. But again, I would start with the health department, and we can ask if facilities who are fearful outside of those required visits, if they're allowed to delay visits or delay and postpone indoor visiting for a while until the transmission rate goes down.
Can you provide detail on facility-acquired cases? If a staff member has tested positive but got it from a family member, does this case not count?
It counts if they were in your facility at any time during their incubation period or after. So if they tested positive today and they were in your facility in the last 14 days or so, you need to count them as an outbreak because they've had contact. They've been in your facility.
We are testing our residents every week because of asymptomatic employees. Does this still lock us out until we are done with weekly testing?
Yes, it does. For indoor visitation and outdoor, actually.
If someone visits twice within 72 hours, do they have to be tested twice or just once?
Just once. I would just make sure that they've had a test in the last 72 hours before the visit. So if somebody came in every day, you don't have to test them every day. You probably only have to test them every 3 days.
The handouts from Leading Age state testing required for visitors at the top. However, this does not apply to HFAs, so this handout is not helpful to share with staff, residents, and family members of HFA residents.
Which handout are you talking about? Well, shoot me an email and so that I know which handout you're specifically talking about. But you're correct. The testing is not required for anything other than nursing homes.
Does a nurse have to perform POC testing on visitors? Already answered that. As of today, no indoor visits allowed for independent living residents. That's a tough sell to residents. We are an ILAL facility.
Well, technically, the guidance is effective October 26th, Monday. That might put you in a bind to some degree. I think you'll have to figure out a way to work through that if indeed I'm understanding your question.
Okay. Can we advocate to continue visitation if no resident outbreak? We have staff 1 or 2 every few weeks, and our source control is working well.
I think that the department would say no to that, as long as you've got some positive people in your facility. If they've been in any kind of, if they've been in the facility at all, it doesn't even have to be in close contact with residents. If they've been in your facility at all, they're going to consider that an outbreak, and you're not going to be able to have visiting.
If POC testing is not available, will rapid testing results from another source, such as an urgent care, be acceptable to allow in an indoor visit?
I would think, yes, it would be acceptable. The thing that I'm not sure about is whether or not they're going to pay for it. I think that the state has rules about if they allow such a thing, they're not going to pay for an urgent visit. I don't think they're only going to pay for the test. So I think that there might be some barriers there. But we don't have the financial support guidance yet, so we'll have to see. But we do want to submit these kinds of questions to them in advance.
Do end-of-life visits and ADL visits need to be supervised?
My understanding is that all visits have to be supervised.
Okay, and all visits cannot be more than 15 minutes, correct?
No, that's not true. Close contact has to be limited to 15 minutes or less. You can decide the length of your visits based on your needs and your staffing and your infection control ability and the space of your facility. That is something that hasn't been mandated at all by the state. That is up to facility policy. You just have to make it work within the other guidelines.
How will we be notified when county risk levels change? Do we need to check every day? Our county is risk level E. Do we need to be prepared to open up the day we change to D?
We talked a little bit about the fact that some of these risk levels can go up and down very quickly at a county level. And even though I believe it's based on a 7-day rolling average, it still can go up and down quite a bit. I think you're going to have to check whenever we figure out where the ongoing link is going to be. You're going to have to check every day, I believe. However, there might be some transition time. I'm pretty sure that if you go from a low risk level to a high risk level, you're probably going to have to shut down visitation right away. But if you're going the other direction, there might be some time frame that to allow you to transition. CMS guidance has a time frame in it, although we don't use it right now in Michigan.
Did the decision makers consider the time it would take for a staff member to conduct the testing on site for visitors with an EOP machine?
I don't think so. I think that their goal, and under considerable pressure, was to make sure that they could figure out a way to make indoor visitation palatable to them, especially the epidemiologists who have grave concerns about transmission. I don't know that they considered that at all. I think that the testing in their mind is required for safety. So unfortunately, we understand that it's going to be an increased burden. Testing of the staff on an ongoing basis is a burden. And we will, of course, talk about that to some degree, but I'm not sure that there's a whole lot that the state is going to be able to do about that piece, but we will communicate that.
Are there any requirements or restrictions for independent living at this point? And if there is an IL positive resident, do you have to report to entire campus, including SNF and assisted living?
First of all, there is no visitation requirements after October 26th for independent living. It may even be gone now, but I'm not 100% sure of that since the new guidance rescinds old guidance as of October 26th. So I would say that the rules are still in effect until that time. If you have a independent living positive person, repeat the question for me so I have it right, will you, Blake?
1 second. I actually have to find it again. I just moved it. Are there any requirements or restrictions for independent living at this point? And if there is an IL positive resident, do you have to report to the entire campus, including SNF and assisted living?
To my knowledge, you do not have to, as long as you are a separate building facility with no crossover. That's that part of the issue when you have a multi-level care on one campus. That part we're going to have to talk to the state about. But right now, independent living alone has no requirements at all as of October 26th. It's not included in any of the orders. So none of the rules would apply to you, except if you are adjoined, that might be an issue with other levels of care. And it might depend on your structure, your physical structure, and how, if you have any pathways or communication between the buildings. But that is a piece that we intend to talk to the state about.
It also states religious providers are not allowed for E. What about when part of staff or for end of life?
I would think that for end of life that would be appropriate. Let's see, they would be non-medical service providers, testing required, no social distancing. I'll have to go back through the guidance, but I cannot imagine not allowing them at any level for end of life care. We'll add that to the list if it's unclear when I go back through the guidance.
We were told on the MDHHS call that they are allowed and that the wording was confusing in the order.
Okay, good. Then we will ask the question though anyway, because it's important to get them to tell us these things in writing. I'm much more comfortable when we have something to refer to in writing.
You had said testing needed to be done for compassionate care visits, and those are allowed under E.
So this graph that I have in front of me says that testing is not required for end-of-life visits for visitors. If that's the question, it says no. But it does say for a serious or critical condition or hospice care. That makes no sense to me. I still am struggling with that. Sometimes I think when they mean end of life, they mean end of life. So we're going to have to talk a little bit more about that because people, we were using a very broad definition of end of life, or at least I have for a long time, that included all of those subsections of serious critical condition or in hospice care. So I think we're going to have to get some clarity about that.
In addition to indoor and outdoor visitation stopping, if you have a positive, you also have to stop non-medical service providers.
I don't think so. Can you go back a few slides, please, Blake? And then repeat the question for me. Leave it there.
In addition to indoor and outdoor visitation stopping if you have a positive, you also have to stop non-medical service providers?
No. Okay, so if you look at this slide, remember visitation restrictions don't apply. Testing requirements might, but visitation restrictions do not apply to non-medical service providers, medical service providers, all these other people.
Can we have compassionate care visits when in level E? You only mentioned we can have EOL and ADL.
I'll be honest with you, I am very confused about compassionate care, end-of-life care, and hospice care, which in my mind were kind of all the same. And they have divided them out. So we're going to have them clarify some of that for us.
Some of the paperwork we got with the POC machine, as well as what we were told on one of the trainings, said you had to be a licensed professional, so we took that to mean a nurse or maybe a certified MA, etc.
Okay, all right. Well, and we will talk to the department about that. I think that's burdensome, and to me, it's one test that I think could be learned, but we'll talk more about that.
How often would a visitor need to be tested? Every 72 hours?
When they come to visit, they have to have a test within the last 72 hours. If they haven't had a test in the last 72 hours, you should test them.
Is there a specific definition for well ventilated?
No. I've tried to get that myself. I'm not getting anything from the department about outdoor structures or indoor ventilation. They simply let those phrases stand as they are written.
We are hearing from our vendors that we can get additional testing supplies for POC testing for families. They are only allowing orders for staff and residents. Is anyone else experiencing this?
Well, I don't know. We can ask that question out on the listserv, but I believe that it is the intention of the department to actually send you test kits.
Okay. Perhaps you misspoke. The employee or visitor is not required to supervise a visit, but must be available for questions per the order. Am I correct? You said it had to be supervised.
Visits have to be supervised. Go back one slide, will you please? Visits have to be supervised. The person, go back another one. The person who has to be trained in infection control and available is not required to supervise. So you don't have to have a highly trained person doing supervision. However, you do have to monitor these visits. Go back. Okay, stop. Ensure availability, third bullet down, of adequate staff to assist with transition, monitoring of the visitation, and cleaning to disinfect surfaces. So these visits must be monitored to ensure that there's no inappropriate transmission possibility.
Okay. Go to the go to that infographic. It says non-medical service providers. I believe that's talking about a question from a few ago. Would it be this one?
That's what they're talking about. I'm not sure what the question was. So let's move on, and I will try and figure out the question when we get it in writing.
Okay.
When I get it in writing.
The slide with visitation restrictions conflicts with the grid. The slide says restrictions do not apply to resident physicians and clinical students, but the grid says they may restrict based on county level outbreak.
Yes, I agree. So we'll talk about that.
Can you please clarify the graphic that seems to indicate that the residents' physicians cannot visit during an outbreak?
That's the same question. We'll have to work on that. That was never my understanding before. And actually, it wasn't my understanding as I read the text, but it does seem to say that here. I do know the department put a lot of time and energy in this, but I still think that the graphic is confusing.
When do you anticipate the Q&A be released from the state?
Oh, I have no idea. I cannot ever anticipate the state. They can't even, they're not even sure themselves. And that's not a criticism. It's just that they are moving hard and fast as we are. We hope to get our list to them very soon, by tomorrow, I think. And I will be going through our Q&A tonight. We will be working toward kind of categorizing these questions, figuring out where we think that there are major issues, and ensure that we can send those off to the state. Now, how long it'll take for them to either get a reimbursement guidance out or the Q&A, I can't really say.
All right, it looks like that was the last question. So if you think of anything else after this webinar has concluded, feel free to shoot that email over to either Deanna or Safe and Calm so we can add it to the Q&A. Other than that, we would like to just thank Deanna for obviously figuring out all this information. And we would also like to thank, I believe we had around 85 members and participants that took time out of their busy schedules to join us tonight. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that we will be having our another scheduled Safe and Calm webinar tomorrow, Friday morning at 11 a.m. Eastern Standard Time, and you should receive your email notification as usual. And I hope everyone has a great rest of the night, and we will talk to you all tomorrow morning.
Thank you, Blake. Good night.